Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for this clinical clip titled Neurofibromatosis Type 1 Related Plexiform Neurofibromas, Key Advances from the American Society of Clinical Oncology 2025 Annual Meeting. My name is Dr. Amy Armstrong, and I am an Associate Professor of Pediatrics in the Division of Hematology and Oncology at Washington University School of Medicine. One of my areas of expertise is treatment of plexiform-related neurofibromas in the NF1 setting. In this clip, I will highlight key data presented at the conference in Chicago, which was an absolute whirlwind the past couple of days. So regarding talks that revolved around treatment of plexiform neurofibromas in NF1 patients, there were three major talks. Two of them were in poster form, and the last one, which I will review, was an oral presentation. They all revolved around usage of MEK inhibitors targeting the hyperactive RAS pathway, which we have found successful over the past couple of years in the treatment of plexiform neurofibromas in NF1 patients. And as you all may know, we now have two FDA-approved MEK inhibitors here in the United States, two for the treatment of pediatric patients, looking at selumetinib and mirdametinib, and then one now for the treatment of adult patients being mirdametinib, most recently approved in February under the FDA here in the United States. The question is really treatment around the world, and two of these first abstracts are targeting the international population and evaluation of other MEK inhibitors in those patients. So I'll first review a poster abstract, which was an open label phase 1 dose escalation and dose expansion trial to evaluate the safety, tolerability, and efficacy of TQ-B3234 in adults with NF1 and inoperable plexiform neurofibromas, malignant peripheral nerve sheath tumors, or cutaneous neurofibromas. And I had a chance to briefly speak with the investigators as well at the meeting, which was really nice. The primary endpoint for their study was the overall response rate assessed by investigator using the RAINS criteria for NF1 plexiform neurofibromas. Additionally, for malignant peripheral nerve sheath tumors, they allowed evaluation with RECIST criteria. However, that data was not available on their abstract results. More importantly, the medication TQ-B3234 is a selective MEK1/2 inhibitor, and a phase 1 of this study started with dose escalation from 5 milligrams dose daily to 100 milligrams dose daily. It was a little unclear to me if they entirely followed a 3x3 design as they had outlined in their abstract, but they ultimately moved forward with dosing at 50 milligrams and 70 milligrams for the dose expansion phase. It appeared that the bulk of patients treated with this MEK inhibitor were dosed at the 50 milligram dosing, with 20 patients within that cohort. Treatment-related adverse events seen in the majority of patients, which were 39 of 40 treated, were namely grade 1 or 2 in their severity. And then there were also a few grade 3 treatment-related AEs reported in 15% of patients, namely those who were dosed at the 50 milligram level or above. Treatment emergent AEs also included acneiform rash, diarrhea, and edema. And I'll say when I was looking at the AE profile, pretty similar from what we typically see with MEK inhibitors to date. There were 30 patients where we could evaluate, or they could evaluate, the change from the baseline size of plexiform neurofibromas to their follow-up time at 12 months. And the overall response rate within this population was 36.7%. So 11 out of 30 patients who had NF1-related PNs achieved a partial response, which was at least a 20% reduction in tumor size from baseline while on treatment. They were noted that a variety of plexiform neurofibromas remained stable while on treatment, so not quite meaning that 20% reduction, but not necessarily progressing. But when I asked them if any of those patients were actually progressing when they started treatment, they were unaware of that data. So I think it becomes very strong if we know that tumors are growing, and then when we start treatment that you become stabilized. A little bit less clear if you're starting on treatment already as a stable tumor and you remain stable while on medication. Furthermore, they had 7 patients with cutaneous neurofibromas, 6 had at least 1 tumor assessment with paper frames, and ultimately all of these patients experienced a reduction in their tumor size. This group concluded the safety profile was manageable, with a significant overall response rate in adult NF1-PN patients, and the potential for this drug to become a new treatment option. Moving on to the next abstract that was looking at the treatment of MEK inhibitors in pediatric patients with NF1-related PNs. I'm going to review the data from a group where their poster was available to review, but unfortunately I was not able to speak with them directly. However, some of their data is also starting to move towards published format, and so I've been able to have a sneak peek into that as well. Ultimately, this group was using FCN159, which is a luvometinib in pediatric patients. And the data presented here is from a multi-center, open-label, single-arm phase 2 study. Ultimately, FCN159 is a highly potent selective inhibitor of MEK1/2. The recommended phase 2 dose that this group was looking at was 5 milligrams per meter squared in a phase 1 study. And here they report the updated efficacy and safety data observed during the phase 2 study in pediatric patients who were dosed at 5 milligrams per meter squared once daily, continuously. This trial was conducted at 6 sites in China. They ultimately enrolled 46 patients who had inoperable measurable tumors. And the median age of population here was 8 years. Most common complications due to the PNs were disfigurement, occurring in 70% of their population, and pain in 63%. The primary endpoint was investigator-assessed overall response rate per the Raines criteria, and secondary endpoint was a blinded independent central review assessed overall response rate, and they looked at other efficacy endpoints, safety, and clinical outcomes. Ultimately, 46 patients experienced treatment-emergent adverse events, and 45 had treatment-related adverse events, 21.7% of which were grade 3 or above, including acneiform rash, a blood CK increase, folliculitis, paronychia, and along with 1 patient who at least had an upper respiratory infection, ejection fraction decreased pneumonia, or pangina, anemia, and a GI disorder. Efficacy was reported in 43 of these patients with a median follow-up of 25.1 months. The investigator assessed best confirmed overall response rate. There were no complete responses. All of these were partial responses with 60.5%. And after a blinded independent central review, this number went down to 44.2%. The median duration of response and progression-free survival was not reached in this study. And assessing overall tumor pain, the study noted that reduction in pain scores were seen, but it was unclear the level of significance for this reduction. And the number of patients evaluated for pain overall seemed a bit low, only 9 to 13 patients out of their entire cohort, which was over 40. Overall, the study concluded that FCN159 has promising anti-tumor activity in pediatric patients with NF1-related PN, with favorable tolerability and manageable toxicities, also aware that long-term follow-up was in progress. So these are the 2 poster presentations looking at different MEK inhibitors, primarily international use right now, so China included. And then we'll move on to the last major study update from ASCO regarding treatment of NF1-related PNs, which was an update from the COMET study. This one was provided an oral presentation, and as soon as the presentation was complete, the presenting author, Alice Chen, also noted that the study is now published in Lancet. So I'll review some of the key findings, but feel free to access the article as well in Lancet, which might be even more detailed. All right, so this study was looking at selumetinib, which is a MEK inhibitor that's been FDA approved in the United States for pediatric patients since April 2020. And this study was an ongoing multi-center international randomized placebo-controlled double-blind trial using selumetinib 25 milligrams per meter squared in adult patients with NF1-related PNs. As a little bit of background, as I said, the selumetinib has been approved since 2020 for treatment of pediatric patients. This really came from the landmark SPRINT study. And in that study, and I think it's helpful to kind of understand some of these percentages earlier on, but in the pivotal SPRINT study with pediatric patients, 68% of pediatric patients with NF1-related PNs had an overall response rate with the use of selumetinib, so at least a 20% reduction in pain, and also clinically meaningful reduction in pain scores using the NRS 11 scale. Furthermore, there was an NCI-led adult open-label study with selumetinib where a 63% overall response rate was seen. Now, what's really interesting about this study was the first one to date that randomized to a placebo. And so it was a 1-to-1 randomization to placebo or selumetinib for 12 cycles with a crossover period from placebo to selumetinib at the end of cycle 12 or at confirmed radiologic progression. The primary endpoint of the study was looking at overall response rate, which was defined as partial response or complete response per the RANGE criteria by cycle 16, and comparing that with selumetinib versus placebo. However, I'd like to note that this included patients who crossed over from placebo to selumetinib. So patients may have been on placebo for 12 months, and then they received another 4 months of selumetinib, and then the imaging was reviewed after those 16 months or by cycle 16 to look at overall response rate. So not a completely clean placebo versus selumetinib group. There were overall 184 patients who were enrolled, 145 adults randomly assigned to selumetinib, N equals 71 for that population, or placebo being N equals 74. So 74 patients received placebo and 71 patients received selumetinib. Overall, 100% of the selumetinib participants and 92% of the placebo participants had at least one adverse event. Most frequently reported were dermatitis acneiform, an increase in CK, and diarrhea. The placebo group also noted some adverse events such as nausea and fatigue, which is kind of interesting that in this population, even while on a placebo drug, that some patients are noting side effects that they were relating to that drug per se. In the selumetinib group, there were 5 patients or 7% who had a grade 3 increase in CK, or creatinine kinase, phosphokinase, and all other grade 3 events were no more than 2 participants. Dose reductions occurred due to adverse events in 10 patients or 14% of the selumetinib population and in 4% of the placebo population. Most interestingly, selumetinib led to a rapid response, meeting at about 3.7 months for these patients with an overall response rate of 20%. So 14 out of 71 patients who were randomized to selumetinib ultimately demonstrated a partial response, or at least a 20% reduction in tumor volume or plexiform tumor volume while receiving selumetinib. The confidence interval for this ranged from 11.2 to 30.9%. And again, this overall response was reviewed by cycle 16. And this was in comparison to 5% in the placebo group. So 4 out of 74 patients also had a partial response while on placebo. And they deemed this to be statistically different with a p-value of 0.011. But just again to claim that some of these patients who were on placebo also received 4 cycles of selumetinib. Now, in regard to pain, over 80% of the COMET participants had PN-related chronic pain at baseline, so a large majority. They ultimately used a PAINS Plexiform Neurofibroma measure, which kind of uses an NRS 11 scale for evaluating chronic and spike pain. Participants in the placebo group reported some pain reduction before they crossed over to selumetinib. So the question was this a placebo effect? Patients' awareness of pain may have increased while on study, and they were also using a daily e-diary. There, however, was no meaningful decrease seen until after the crossover in regard to pain in that population. Patients with a baseline chronic pain score of at least 3 or higher had a greater reduction in PAINS Plexiform Neurofibroma scale in their target plexiform neurofibroma. However, the difference between being on selumetinib versus placebo and really looking at these chronic pain scores did not reach statistical significance. I would add that reduction in pain throughout was clinically meaningful, and a greater decrease was observed in overall spike pain. Then furthermore, the study noted no significant differences were observed between selumetinib versus placebo in the Plexi quality of life total score. So ultimately, the study met a clinically insignificant overall response rate for selumetinib versus placebo with a clinically meaningful reduction in chronic target plexiform neurofibroma pain and a manageable safety profile, which I would say is pretty equivalent to a lot of our other studies using MEK inhibitors to date. But I would also add that the study raises some very important observations. Now, first of all, this was the first placebo-controlled randomized phase 3 trial using a MEK inhibitor and in adult populations with international influence. I think of maybe about 4 U.S. sites were involved, but the remaining sites were internationally. And I think this raises a question at how these plexiform neurofibromas are evaluated from a radiologic standpoint, how we're really using these value measurements, and if things are consistent amongst the trials, given the slight difference in overall response rate reported by COMET versus earlier studies, which again, I said was above 60% or so in pediatric and adult patients who are on selumetinib versus just a 20% overall response rate in this study. The study did argue that the overall response rate was evaluated after 16 cycles, but however, on these other studies, patients were on drug for longer time periods. So it could be that we aren't establishing the response of some patients if they would have remained on the drug for longer, as we are continuing to evaluate. And to add to that the treatment cycles for patients who are on the SPRINT study went up to 36 cycles when they were able to evaluate for response, and 28 months of data cut off for the open label selumetinib study in adults that was run through the NCI. Really interesting food for thought. I think that understanding that MEK inhibitors are important for plexiform neurofibromas just adds more fuel to the fire and treatment options for these applicable patients. I'd always add, and I say this in a lot of my teachings into our residents and fellows in clinic, is just because you have a plexiform neurofibroma in the setting of NF doesn't necessarily mean that you need medical treatment. But for those patients who are truly in need and surgery is not an option, knowing that there are a lot of different MEK inhibitors that are out and seem to be successful, I think is really important. Also understanding that the safety profiles are pretty similar amongst the MEK inhibitors, especially as we're trying to compare one versus the other. And then most importantly in this COMET trial, really understanding the methods for efficacy, why things might be a little bit different from some of the US controlled trials versus more the international trials, and also raises the question of patients who have different races or ethnicities, if that influences any of the biology behind plexiform neurofibromas as well. So definitely some questions that come to my head when I'm looking at the results from these studies to date. So in general, I would like to thank you for joining us for this clinical clip titled Neurofibromatosis Type 1 Related Plexiform Neurofibromas, Key Advances from the ASCO, or American Society of Clinical Oncology 2025 conference. And please be sure to click on the landing page for this activity to claim your AMA, ANCC, or ACPE credit and access downloadable slides. Thank you again for the participation.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.